Hi my dear students, this is Dr. Jeetu. Today we will be discussing the last unit in the Dental Pulse about pharmacology, that is general pharmacology. First we will see the routes of administration of drugs. It is broadly divided into enteral, parenteral and local. So first is enteral. Enteral means oral, The oral cavity is also known as the enteric cavity. So enteral route means by mouth. It is the most commonly used route. It is the oldest and safest route of drug administration, because as soon as we think drugs, we will be thinking about ingesting a tablet and having some water. So that is the commonest and the safest route. Now, every other route other than enteral is known as parenteral. Usually we get confused thinking parenteral means injections. It's not like that. Anything other than enteral is parenteral. And parenteral routes include injections, inhalation, transdermal and transmucosal routes. Now we will see some injection techniques. One is intradermal. Intradermal means drug is injected into the dermis or into the layers of the skin, and this raises a bleb. You can see it is the rightmost figure. When we are injecting into the epidermis, then angulation of the needle is 10 to 15 degrees. That is, it is close to parallel. Then only we can confine it to the layers of the skin. What is an example? BCG vaccine is given intradermally and test for allergy. Before giving local anesthesia for dental extractions and all, we usually test for allergy for LA. This is also, if you remember, given intradermally, raising a small bleb. So that is intradermal. Next is subcutaneous. Subcutaneous means below the skin or under the dermis layer. Here we have fat tissue. So the absorption here is less because it is less vascular, and this makes the drug long acting. It is a reliable route of administration. Patients can be trained for self-administration. For example, insulin injections. Usually most of the diabetic patients take insulin injections of their own. It is by subcutaneous route. Heparin is also given subcutaneously. Coming to intramuscular route, the first figure from the left is intramuscular injection. Aqueous solutions of the drug is injected into large skeletal muscles in this case. The muscles usually used are deltoid, triceps, gluteus or rectus femoris. Drugs are absorbed faster from the deltoid region than gluteal region. So it is better to take on the hand, especially in women. So that is about the muscles used and which muscle is better. For infants, rectus femoris muscle or the thigh muscle, it is used instead of the gluteus, because gluteus is not well developed in a child until the child starts walking. Clear with that? And one more thing to note from the figure is intramuscular injections are given at 90 degrees. It is injected perpendicularly so that it reaches the deepermost muscle. Then we have intravenous, means into the vein. Here, drug is injected into a superficial vein so that it directly reaches the circulatory system. That is the third figure. Here it is given at almost 25 degree angulations, more than the intradermal's angulation. Subcutaneous is usually given at 45 degree angulation, and this is having an in-between angulation, almost 25 degree angulation, so that it reaches the blood vessels in the dermis layer. By three ways we can give intravenous injection: bolus, slow injection and slow infusion. Bolus means when an initial large dose of the drug is required, we give a bolus injection. For example, heparin. Slow injection means the drug is injected slowly over a 15 to 20 minutes time. For example, antibiotic injections like aminophylline. And slow infusion is a large amount of the drug, usually about 1 liter of the drug is infused over 3 to 4 hours. The glucose drips and all we receive is a slow infusion technique. Coming to intraperitoneal. What is peritoneum? Peritoneum is the abdominal cavity where all the organs are suspended. So this peritoneum offers a large surface area for absorption. Fluids can be injected into a peritoneum in infants. It is also used for peritoneal dialysis. Next is intrathecal. Intrathecal means drug is injected into the subarachnoid space into the CSF or cerebrospinal fluid so that the drug acts on the CNS. Spinal anesthesia is given intrathecally. So the term you should keep in mind, the intrathecal is into the CSF. Next is intraarticular. Here drugs are injected directly into a joint, into the articulation or the joint. This is for the treatment of arthritis and other joint diseases. Now intra-arterial means into the arteries. Drug is injected directly into the arteries. It is used only for these three indications. 1 is for peripheral vascular diseases, 2 is for local malignancies, and 3 is for diagnostic studies like angiograms. Otherwise, if you are injecting into a vessel, it is usually into the vein. Intra-arterially, we inject only in case of peripheral vascular diseases, local malignancies, and diagnostic studies like angiogram. And finally, we have one more injection technique, intramedullary, means injection directly into a bone marrow. After the first parenteral route injection, coming to inhalation. Volatile liquids and gases are given by inhalation. For example, general anesthetics. To induce general anesthesia, we use gases and it is given by inhalation. Coming to transdermal. There are three transdermal techniques: inunction, iontophoresis, and jet injection. Inunction means the drug is rubbed onto the skin and it gets absorbed to produce systemic effects. So rubbing of any drug into your skin is called inunction, maybe a new term. Then you have iontophoresis. Here galvanic current is used for bringing about penetration of the drug into deeper tissues. You know our cell membrane has a lipid bilayer. So if a drug is lipid insoluble, then you have to use a galvanic current to force this drug to deeper tissues. Then you have jet injection. Even though it is an injection, it is considered as a transdermal technique because absorption of drug occurs through skin layers. Okay. Coming to transmucosal, there are 3 transmucosal routes: sublingual, nasal, and rectal. Sublingual means the formulation is given under the tongue. Usually the drug should be lipid soluble. Example, nitroglycerin, nifedipine, etc. Nitroglycerin, you are very familiar. Sublingual nitroglycerin tablets for angina. Then you have a nasal route. In nasal route, you can use a nasal formulation for local effects as well as for systemic effects. For local effects, you use decongestant nasal drops like oxymetazoline drops. Sometimes you give nasal administration of oxytocin. This is for systemic effects. So that is about nasal. Finally, rectal. The rectum has a rich blood supply and drugs can cross the rectal mucosa and it can be absorbed for systemic effects. Drugs like diazepam and NSAIDs like indomethacin are also given by rectal routes. So these are the 3 transmucosal routes: sublingual, nasal, and rectal. Coming to topical. Topical application means ointments or creams that can be applied onto the skin or onto the mucous membrane are topical applications. Some different names about topical applications are suppository for rectum. In rectum, we keep rectal suppositories, and Baucher for urethra. If you are keeping any drug for urethra, it is called Baucher. And pessary and dosh are the topical route of administration used for vagina. So suppository for rectum, Baucher for urethra, and pessary and dosh for vagina. Finally, there are some special routes of administration. One is Occusert. Just know what all these terms means. Occuserts are thin elliptical units that contain drug in a reservoir and this slowly releases the drug through a membrane by diffusion. For example, pilocarpine Occuserts are used in glaucoma and it releases pilocarpine for 7 days. Then you have osmotic pumps. It is a tablet-shaped unit with 2 chambers. One has the drug and one has an osmotic substance. You swallow this tablet and it reaches your gut. Then water will enter the tablet through its semi-permeable membrane. Then the osmotic layer will push the drug layer and drug will be slowly released. It's also known as gastrointestinal therapeutic system, GITS. Next is computerized miniature pumps, wherein it is programmed using computer to release the drug at a definite rate. Monoclonal antibodies, you are familiar. It is against tumor-specific antigens and used in anti-cancer drug delivery. Then you have lysosomes. Lysosomes are phospholipids suspended in aqueous vehicle to form minute vesicles. The drugs encapsulated in liposomes are usually used for treating malignant tumors. So, Occuserts, osmotic pumps, computerized miniature pumps, monoclonal antibodies, and liposomes are special drug delivery systems. After a drug is administered, 2 things happen in our body. One is pharmacokinetics and one is pharmacodynamics. Pharmacokinetics means what our body does to the drug. After a drug goes inside our body, what all our body will do? It will transport, absorb, distribute the drug, then it metabolizes and excretes the drug. Pharmacodynamics means what the drug does to the body. Dynamics is the actions of the drug. So connect the D and D. Dynamics is what the drug does. What the drug can do to the body. The drug-body interaction through the receptors to exert its effect is called the pharmacodynamics. Now you know the different routes of administration. After drug is administered, it should be transported in our body. So you have to learn the mechanisms of transport. One is simple diffusion. Simple diffusion, you know, it is the transfer of a drug across a membrane in the direction of its concentration gradient. High concentration to low concentration, and our cell membrane is having a lipid bilayer, we know, therefore lipid soluble drugs are transferred like this. Next is facilitated diffusion. It is a diffusion, but we say it as facilitated because its transport is facilitated by a carrier protein. Okay, so that is simple diffusion, facilitated diffusion. Now filtration. Filtration means the drug passes through pores in the membrane. So it is not dependent upon dissolving inside the lipid bilayer. Therefore, water soluble drugs are transported like this, and the drug size should be less than the pore size. Finally, active transport. All these are passive transport because there is no energy involved. In active transport, energy is involved because transfer of drugs occurs across a concentration gradient. That is opposite, means low concentration to high concentration the drug should move, and it needs a carrier protein. Usually active transport happens in our body only for drugs related to natural metabolites like levodopa, iron and amino acids. Coming to absorption, a number of factors affect absorption. How the drug is formulated, and after the particle size of the drug, whether it is soluble, whether it is insoluble, the vascularity of the absorbing surface, any diseases of the gut, all this can affect the absorption of a drug. Some important questions from this area are, what is the rate of absorption of lipid soluble drugs? Lipid soluble drugs are always absorbed faster and better because they can be dissolved in the phospholipids of the cell membrane. So about lipid solubility, lipid soluble ones are absorbed faster. Then coming to ionized and non-ionized drugs. Ionized drugs are poorly absorbed and unionized drugs are usually better absorbed. Why? Because unionized drugs are lipid soluble. Then we have another term, gastric emptying time. If the gastric emptying time is faster, the drug will pass the stomach very fast and they move to the intestine. And intestine is the region where most of the drugs are absorbed. Hence, absorption is faster if gastric emptying time is faster. Then intestinal motility. When intestinal motility is increased, example as in diarrhea, drug absorption will be reduced because we already mentioned intestine is the area where most of the drugs are absorbed. Coming to first pass metabolism or pre-systemic metabolism. It is the metabolism of a drug during its first passage through the gut wall and the liver. So it is applicable only in case of orally administered drugs or enteral route of drugs. Since when the drug is passing through the gut and the liver, its metabolism already starts happening. This will reduce the bioavailability of the drug. The drugs undergoing first pass metabolism, I remember it like this. First pass proper mint valley. So proper is propranolol, mint, M is morphine, I is insulin, N is for nitroglycerin and T is for testosterone. And in valley you have V for verapamil, A for alcohol and L is lignocaine. So all these drugs show first pass metabolism. First pass proper mint valley. Clear with that? Another important question is, what are the three important pharmacokinetic parameters? These are bioavailability, clearance and volume of distribution. Bioavailability is the fraction of a drug that reaches the systemic circulation following administration. You administer a drug by any route, only a fraction of it is reaching the systemic circulation. This is the bioavailability. So if the drug is given IV, directly you are putting it into the systemic circulation or into the bloodstream. So the bioavailability is 100% for IV administration. Next term is clearance. Clearance is the volume of plasma that is freed completely of the drug in unit time. So how much amount of your plasma is getting freed of the drug in unit time. So how much is getting cleared. This formula is plasma concentration divided by rate of elimination. Volume of distribution is relating the amount of drug in the body to the concentration of drug in the plasma. When you are taking a drug, you are taking it into your whole body and how much of it is going into the plasma. So volume of distribution is the plasma concentration of the drug by the amount of the drug in the body. Another very important term regarding pharmacokinetics is dose response curve. That is, as you increase the dose of a particular drug, the response our body gives also increases, but only up to a particular point. after a particular point, even if you increase the dose, the response will not increase. That is why the dose response curve is a rectangular hyperbola. You can see from the figure, after a particular point, it is flat. Even if you increase the dose, response is not increasing. If the dose is plotted on a logarithmic scale, then it will become log dose on the x-axis and response on the y-axis. And this curve is a sigmoid. This dose response curve has a high clinical significance. That is, a steep slope of the dose response curve indicates that with a small increase in the dosage, it can produce a large response. For example, there are two curves A and B. The curve A is a steeper slope. So you can see from the figure, I have denoted the increase in dosage on the x-axis from x to y. The point x to point y shows the increase in the dosage. Then try to plot the increase in the dosage on both the curves. When we are plotting the increase in dosage on the curve A, you can see that with the blue lines, it is giving higher magnitude on the y-axis or a higher response. Now look at the yellow lines, that is when it is increasing from x to y, try to plot it with the curve B. Corresponding to curve B, the response that is increasing is minimal when compared to the response that is increasing with the curve A. An example for a steep slope DRC is loop diuretics. With very small increase in dosage, there is a good response. And for almost flat DRC, it is thiazide diuretics. Okay, so drugs with steeper DRC has to be used with caution, whereas those with flatter DRC can be given in standard doses to most of the patients. Now, what will happen when you do repeated dosing of a drug? Three things can happen. One is accumulation, one is tolerance, and one is tachyphylaxis or acute tolerance. Accumulation is drugs like digoxin, which are slowly eliminated from our body. When we do repeated dosing, what will happen? They accumulate in our body and this will result in toxicity. So that is what happens with repeated dosing of drugs like digoxin. Tolerance means it is a requirement of higher doses to produce a given response. For example, drugs like morphine, on repeated dosing, what happens later on, the given dose won't be enough to elicit a response. You will have to give higher doses of the drug. And finally, tachyphylaxis or acute tolerance. This is the rapid development of tolerance. That is, when a drug is administered repeatedly at short intervals, the patient acutely or rapidly become tolerant to that drug. Now coming to two similar terms which may confuse us, potency and efficacy. So what is potency? It is the amount of drug required to produce a response. To get a response, at least this much amount of drug is required. So if we have to get the effect diuresis, 1 milligram of bumetanide is enough to produce diuresis, whereas at least 50 milligram of furosemide is required to produce diuresis. So which is more potent? Obviously, bumetanide is more potent, meaning to say with a very minimal amount of bumetanide, that is 1 milligram, it can produce a response called diuresis. So clear with potency. Now comes efficacy. Efficacy indicates the maximum response that can be produced by a drug. That is, we already said only if there is 50 milligram of furosemide, it can show its action of diuresis. But furosemide is very efficacious because it can produce powerful diuresis that cannot be produced by any dose of amiloride. Once we give 50 milligram of furosemide, its efficacy is so high that it can produce very powerful diuresis that cannot be produced by any dosage of amiloride drug. So that is potency and efficacy. Now this is an important figure. Let us try to find out potency and efficacy from the dose response curve. There are 4 drugs A, B, C and D. First let us see about A. With the most minimum dose of the drug, A could produce a response. With only higher doses, B, C and D could produce a response. But see the heights of the curve. Curve B is showing the maximum height, or even if it requires a larger dose to produce a response, B is producing the maximum response, which means to say that drugs B and C are more efficacious than drugs A and D, which can elicit only a lesser amount of response. But drug A is very potent because with the minimum dosage of the drug, it could elicit a response. Another very important is therapeutic index. Therapeutic index is defined as median lethal dose by median effective dose. Median lethal dose means the dose that can be lethal to or that can kill 50% of the population. And median effective dose is the dose that is effective to 50% of the population. Therapeutic index gives idea about safety of the drug. So just imagine if the median lethal dose is very high or the dose required to kill a person is very high, then the drug is safe or not? Yes, the drug is safer. Similarly, if a drug will produce its desired effect in very low amount, or if the median effective dose is very low, again it is a safer drug. So the therapeutic index numerator, that is LD50, when it is increasing it is safer, and the denominator ED50, when it is decreasing it is safer. So as a whole, when therapeutic index value is increasing, the drug is safer. Higher the therapeutic index, safer is the drug. While therapeutic index was a ratio between the dosages, mean lethal dose and mean effective dose, therapeutic window is a plasma concentration. It is the plasma concentration of the drug below which the drug is ineffective and above which toxicity appears. So within this window is the therapeutic effectiveness of the drug. Below this it is ineffective, above which it is toxic. We should have a plasma concentration of all drugs within the therapeutic range. Now related to this, there is one more term, therapeutic communication. It is not at all related to drugs. They may give this term in the options to confuse you. Therapeutic communication just means the techniques of care used to communicate with the patient, like active listening, explaining them, all these. Now we learned the properties of drugs like potency, efficacy, therapeutic index, therapeutic window, all that. Now when multiple drugs are administered, these drugs show many interactions. We will discuss those. First is additive effect. Additive effect is simple. The effect of two or more drugs gets added up and the total effect will be equal to the sum of their actions. For example, when action of A and B are combined, the result is A plus B. Then synergism. Synergism is when the action of one drug is enhanced or facilitated by another drug. That means when you are giving two drugs A and B together, the effect is not A plus B, the effect is more than A plus B because the action of one drug is enhanced by the another drug. Now what is antagonism? Antagonism is one drug opposing or inhibiting the action of another drug. There are four types. One is chemical antagonism, where two substances interact chemically to result in inactivation of the effect. Second one is physiological antagonism, where two drugs will act at different sites and they produce physiologically opposing effects. For example, insulin and glucagon. They act at different sites but they produce physiologically opposing effects. Then we have antagonism at the receptor level and non-competitive antagonism. The antagonism at the receptor level can be of two types, reversible and irreversible. So first, antagonism at the receptor level, which is reversible or competitive. Here the agonist and the antagonist compete for the same receptor. So as we all know, it is a receptor level antagonism. So the agonist and antagonist both are going to compete for that receptor site. When an antagonist binds to the receptor site, an antagonist receptor complex is formed, as you can see, and when the agonist approaches the receptor site, its binding is denied. This is reversible or competitive antagonism. See, the black colored antagonist and the red colored agonist are competing. Here, if we increase the concentration of the agonist, that means there is maybe one or two black colored antagonist. If you are increasing or if you are putting to the medium so many red colored agonist, then the chance of the agonist binding to the receptor increases and the antagonism can be overcome. Therefore, this type of antagonism is known as reversible antagonism. Look at the graph also. The first curve A is the dose response curve in the absence of a competitive antagonist. B, C and D are the dose response curve of the same drug, but here we increase the dose of the competitive antagonist. So with increasing dose of the competitive antagonist, we have to increase the dose of the agonist also to receive the same amount of response. That is why there is a rightward shift in B, C and D respectively. That means we have to increase the dose of the agonist to achieve the same amount of response. Next receptor level antagonism is irreversible antagonism or non-equilibrium type of antagonism. This is also a receptor level antagonism because the agonist and the antagonist are trying to bind on the same receptor site. But it is called irreversible because the antagonist's binding is so firm and it is by covalent bonds so that it dissociates very slowly or it does not dissociate at all. In reversible or competitive antagonism, as we increase the amount of the agonist, there was overcome of the blockade by the antagonist. But in this case, increasing dose of the agonist cannot overcome the antagonist since its binding is so firm. Hence, it is called irreversible antagonism. In the dose response curve, we can see progressive flattening of the curve. A is the DRC without antagonist. With increasing dose of the antagonist, what is happening? Even if we are increasing the dose of the agonist, the response is diminishing. We are not able to elicit the same amount of response. Now, non-competitive antagonism, which is not a receptor level antagonism. Why? Because the antagonist in this case is not binding to the receptor site, it is binding to a different site known as allosteric site. You can see that brown colored antagonist binding to a different site than the binding site of the agonist. This is called allosteric site. So what happens during this binding? During this binding to the allosteric site, the receptor site of the agonist is deformed so that the agonist is not able to bind to the receptor site. Here also there is no use in increasing the amount of the agonist. The difference in DRC from irreversible antagonism is that there is flattening as well as a rightward shift of the DRC or dose response curve. Let us brush up Km and Vmax, that is in competitive and non-competitive inhibition along with this. In competitive inhibition, look at the figure. There is a receptor site, the inhibitor and the substrate both are looking similar and both are competing for the receptor site. So here, for the substrate to bind to the receptor and for the reaction to happen, we have to increase the substrate concentration. We have to increase the substrate concentration. What is Km? Km is the substrate concentration at half maximal velocity of the reaction. So we have to increase the concentration and Km increases. One more thing is Km is inversely proportional to affinity. We can think it in this way also. When only the substrate is present, the receptor has a particular affinity for the substrate. When inhibitor is also present, the affinity of the receptor for the substrate decreases. Km and affinity are inversely related. Km increases and affinity decreases. Vmax is the maximum velocity of reaction and it is attained when a receptor is saturated with the substrate. Here in this case, if we increase the substrate concentration, we can attain a Vmax that is attainable even in the absence of the inhibitor. So Vmax remains a constant. Clear? So in competitive inhibition, Km increases or affinity decreases and Vmax remains a constant. In non-competitive inhibition, the receptor site is specific for the substrate. The inhibitor binds to another site called the allosteric site. Binding of the inhibitor to the allosteric site will deform the receptor site and our substrate is not able to bind to the deformed receptor site. Here the inhibitor is not similar to the substrate, therefore the receptor site is not having any affinity for the inhibitor. So the affinity for the substrate remains a constant or Km remains a constant. Remaining constant because increasing the concentration of the substrate is in no way going to increase the reaction. So Km is remaining a constant. And one more thing is, since there is no binding of the substrate in the receptor site, there is no reaction happening. Therefore, the Vmax decreases. Coming to metabolism or elimination, there are two types of kinetics. One is first order kinetics and one is zero order kinetics. In first order kinetics, a constant fraction of the drug is metabolized or eliminated per unit time, which means a fraction or a percent of how much amount of drug is present in your body is eliminated in unit time. So it is dependent on how much drug is present in your body, or it is proportional to the plasma concentration of the drug in the body. Most of the drugs follow first order kinetics. In zero order kinetics, not a constant fraction of the drug is eliminated per unit time. A constant amount of the drug is eliminated per unit time. So it is not proportional to the amount of the drug present in the body. It is not a fraction of what is present. It is a particular amount, and it is not dependent on how much drug is remaining in the body. So whatever be the drug remaining in the body, only a amount of that will be eliminated. This means the metabolic enzymes will get saturated, and with increase in dosage of the drug, the plasma level will increase disproportionately, and this will result in saturation of our body with that drug. So it is also called saturation kinetics. So drugs eliminated by zero order kinetics can result in toxicity. We are all familiar with the 0-watt bulbs, right? The bulbs which consume very low power. So to remember the zero order kinetics, we use the acronym 0-watt power. We'll expand it as W for warfarin, A for alcohol, A for aspirin, T for theophylline and tolbutamide, and P for phenytoin. So 0-watt power is used to remember drugs following zero order kinetics: warfarin, alcohol, aspirin, theophylline, tolbutamide, and phenytoin. There is one more type of elimination. It is called Hoffman elimination. Hoffman elimination is the inactivation of the drug in our body by spontaneous molecular rearrangement, and it is not the help of any enzymes. One drug which is eliminated by Hoffman's elimination is atracurium. It is very important. It has been asked as an MCQ. Coming to our last and very important topic, half-life. Half-life, it is clear from the term itself. Plasma half-life is the time taken for the plasma concentration to become halved, to become half of its original value. There is a formula for plasma half-life. It is 0.693 into V by C, where V is the volume of distribution and C is the clearance. It goes like this. In the first T half, 50% of the drug will be eliminated. So what is remaining in our body? It is 50. And what is half of 50? It is 25. So by the second T half, what is lost in the first T half, that 50 plus another 25 will be eliminated, or 75% will be eliminated. Similarly, by third T half, 87.5% will be eliminated, and by fourth T half, 3.75% is eliminated. So most of the drug, or the drug completely gets eliminated in 4 to 5 half-lives. According to this calculation, in first order kinetics, T half will remain a constant because the volume of distribution and the clearance is not changing with the dose. In place of eliminating constant fraction of drug in unit time, as with first order kinetics, in zero order kinetics, only a particular amount, say 1 milligram of the drug, is eliminated per unit of time, which means it is going to take a lot of time to eliminate the drug fully from our body. So definitely the time taken to eliminate half of the drug, or T half, is also getting increased. Okay, from the formula point of view, T half is 0.693 into V by C, and here clearance is very slow, or C is getting a lower value, and therefore half-life is getting a higher value, or T half increases.